go. Okay, there we go. Now we're officially started. The recording is in progress. Thank you, of course. Kia is our backside tech support, the wonderful comm person from the HEAL Initiative. So thank you, Kia. None of this would be happening without you. We're really excited to share both this book and some of the stories behind it and in the making of it. Case Studies in Global Health, Illuminating Theory and Practice. Went through a bunch of names and edited by myself, Jade, Shri, and Fuchs. You'll get to hear from us. But more importantly, you'll get to hear from a bunch of the chapter authors about their experiences and these different stories. So this just came out February 2026. It is available open access. We apologize for the price tag, but at least you can also get it for free in digital form. And thank you, of course, to Sheila Meneses for this lovely cover photo. I wanted to say there are photos throughout the slideshow which are generally from that particular site, but the photos aren't of the case studies themselves. So they're general photos that HEAL uses from those different sites, but not photos of the patients or of the particular case itself. We're going to do questions at the end, but if you have questions as we go, feel free to put them in the chat. We'll collect those and come to the sort of Q&A and discussion at the end. So after this brief welcome, Shri and Fook will talk about the introduction to the book, which also introduces sort of the project and how it happened. Then we'll travel to Chiapas, Mexico, and hear from Anibal and Trisha. Travel over to Haiti with Colleen, Navajo Nation with Claire, Chhattisgarh with Anup, over to Nepal with Isha, and Robin will take us through the conclusion. So thank you, everybody, and I'm going to turn this over to Jade.
Hi everyone, my name is Jade. My name is Jack, but I also go by Jade. I'm here as the table of contents of the book. It starts with the introduction and goes through the various chapters of different locations. And then next slide, please. And then, so first we'll start with Fook and Shri giving an overview of the introduction as well as the origin story of the book.
And just on this slide, we wanted to shout out Vincent Adams, without whom this book wouldn't have happened and many of these relationships wouldn't have come together. She drafted the original draft of the introduction and edited the volume all the way through. It was just incredibly generous and a key part of sort of how this volume happened. Tri and Fook, take it away.
All
All
right.
right, good morning.
Good morning. I'm Shri.
And I'm Fook Blay. So great to see you all. We're very thankful for this community coming together today. I'm going to go real briefly because I think the most important thing on this call is to hear about the particular chapters. Um, so I'll turn it over to Shri right after just talking a little bit about how this book came together. In many ways, the origin of this book is part of the origin of HEAL, the HEAL initiative. As hopefully all of us know, HEAL is the Health Equity, Health Action Equity Leadership Initiative is now about just over 10 years old. And was inspired by our experiences, Sri, and my experiences working in partnership with PIH in 2010 in Haiti after the earthquake. We learned a lot through our late mentor, Paul Farmer, and many, many others in the PIH and Zamila Sensei family, working with doctors and CHWs and nurses uh, and other people in solidarity in January, February 2010. And one of the important lessons that we took from that experience and then continued informing our work at UCSF before HEAL started was really how important it is to, as an outsider especially, to really learn about structural competency, which the words of which we really didn't have back then when we were taking care of earthquake victims And also Sri and I had experience hosting dozens and maybe even up to hundreds of um, very good-willed, well-intentioned clinical volunteers from all around the U.S. and actually even beyond the U.S. And the many failings that our education system in global health equity has potentially led to a lot of harm being caused in resource denied places like Haiti. And I think that's really the origin is, a kind of a humble effort um, that uh, has led really to this gathering. Uh, and there's kind of maybe not a linearity, but definitely some association between that experience more than 15 years ago. Uh, Sri, do you want to add anything?
Yeah, I think not much to add. I would say that Fook and I met during the Haiti earthquake, and I was, like Fook said, I was in charge of supporting some of the volunteers. And I think we had some spinal injury patients in San Mark where I was working in base right after the earthquake, and Fook was the last year resident at the health equity residency at Harvard, and I was trying to transfer some spinal injury patients to him, and that's how we met on a field in Haiti. And I think, he joined UCSF the very next year, and as he was saying, I think one thing that was obvious in the Haiti earthquake response was that capacity building of the Haitian workforce, even many weeks and months after the earthquake, was an afterthought and wasn't core to the work. And so when we started to think about building something like Heal, there was, some creative constraints that we were committed to that I think shapes some of this book as well. We were interested in the work being interprofessional and interdisciplinary. We were interested in supporting health workers that are outside of communities coming in and doing solidarity in a meaningful way, as well as supporting the health workers that are in communities for the long term, running the marathon of the difficult work of doing this work. And so I think, as we know, health workers in off all of the communities in this book and in Heal sites are, too few, overwhelmed, under-supported. And so Heal really tried to exist in that frame of supporting health workers and, in this case with the book, really telling the stories of what they see day to day. Um, and then, yeah, I would say that, yeah, Fook, you could talk about this.
Yeah.
I would say one note about Paul Farmer is that, I was with him the week he passed in Rwanda, and he had generously offered to, you know, uh, write a blurb about the book and support the book, and that last week that he passed. And so there's so many people that have contributed greatly, including Vincent, who's a phenomenal professor that kind of conceived of this book with us back in 2017.
Uh, Thank you, Shri. Yeah, in 2017 and for about 5 years, many Heal faculty and staff contributed to a course that we were teaching at UC Berkeley, undergraduate level course called Introduction to Global Health Equity. And we used Paul Farmer's and Arthur Kleinman's book, Reimagining Global Health. And it was great. It was a wonderful book to use. But we had uh, always felt that there could have been uh, like a partner book that would bring in real cases to really teach a lot of the things that we were trying to uh, uh, instill into our students. And during that time, it was pretty clear to us that the experiences of our Heal fellows all around the world were just super rich lessons for us to teach in the classroom as well. And with Jade and other UC Berkeley undergraduates at that time, uh, really, they put the book proposal together, worked very hard, and then with Vincent Adams, who is a medical anthropology professor at UCSF, introduced us to many, many social theorists and scientists all around the country to pair with our HEAL fellows and to pair the social theory with the clinical cases. So then fast forward 8 years and almost a decade, actually, and here we are now. Yeah.
Yeah. And I think with Heal, very much the immersion of being very close and proximal to the work and proximal to patients and their struggles and accompanying them, that is has always been the greatest teacher. And so trying to have those clinical encounters, those cases be paired with deeper understanding. And so this idea of reflection and action that is so powerful and so important to help us understand the work better, just drove a lot of the volume.
Okay, so as we dive into the chapters, thank you so much, Sri and Fook, for that introduction. After all these conversations, we ended up with 5 case studies in 5 different countries, 28 authors, a number of whom are here today, and we're very excited to hear from everyone. This is just an overview of where we'll be going in the next hour. So let's get into it. So chapter 1, welcoming Anival and Trisha to share a little bit about your chapter, and just let me know as you'd like me to advance the slides.
Perfect. Thank you. Hello, everyone. I'm Aníbal Gutiérrez. I'm one of the authors of the chapter. And this chapter wouldn't exist without the help of my mentors, Trisha and Diane, who I'm very grateful that they are here today with us. Next slide, please. Okay, so I'm just gonna run you through the case. I'm really glad to share this case with everyone because it is a case that I have to this day really close to my heart because it really marked me during my formation as a geriatrician today. So this was Gerardo, a family man, a husband who was diagnosed with intestinal tuberculosis. So he actually went through a lot to get the diagnosis, even spending a lot of the family money and going bankrupt while doing so. And he ended up dying while in transit to Mexico City while seeking further care, which wasn't able to be provided on site. So Anna, the wife, and Viviana, a daughter of age 5, they were patients of us. And since Gerardo was diagnosed with intestinal tuberculosis, we started running different diagnoses on both Anna and Viviana, and we detected HIV and tuberculosis. Each was treated for tuberculosis and other opportunistic infections, and then for HIV to prevent reconstitutional syndrome. It was retroactively assumed that the HB diagnosis of Gerardo was passed on to the wife and the daughter. And they were dependent on the extended family for support and transportation. There was a lot of delays and barriers within the healthcare system in order for them to be treated. Strong Jordan North related to care decision, and afterwards, the daughter experienced a lot of stigma at school and the broader community because of her diagnosis. Even though we were quite careful, since it was a small community, the diagnosis got out, and she had to live with the stigma and the bullying of living with that treatment. So as far as responses to treatment go, Anna died 1 year later from AIDS-related heart complications. It was a sudden death, quite unexpected. I remember it clearly because it was actually my last day in Chiapas as a pasante. But the family was quite grateful with us, and apparently she died at peace. And Viviana, she responded quite well to treatment, and she was now an orphan being cared by her extended family. And I think this case illustrates a lot of the social inequities and the structural violence that people live when they live within marginalized and underserved communities. And I'll let Trisha take over. Thank you.
Next slide. So Paul Farmer helped popularize the social theory of structural violence. Structural violence refers to the social arrangements, our social, economic, and political systems that put individuals and populations in harm's way. And they're structural because they're embedded in how our society is organized. and they're violent because they result in real injury and death. And so when we bring this into the case of our family, Gerardo, Ana, and Viviana, without a structural lens, clinicians may think that Gerardo had delayed care, that Ana didn't follow through, that Viviana didn't improve on treatment. But that perspective is incomplete. And that can often lead to subtle or even explicit victim blaming. But when we apply a structural violence lens, the story changes, and we begin to see that the outcomes weren't just about individual behaviors or non-compliance. They were shaped by systems that made our poor outcomes far more likely and, almost inevitable. So at the interpersonal level, relationships and social dynamics matter. So there are often power imbalances that are between clinicians and patients that can actually limit what informations patients feel safe sharing or able to act on. And in this case, Anna's decisions were really shaped by family dynamics and financial stress that the family was under. And then as Anibal mentioned, that Viviana experienced community stigma related to her HIV diagnosis, which affected her well-being and care. And at the institutional level, the healthcare system creates lots of barriers, right? As we can see, we can be here, that's fine. There is limited access to quality care in rural areas with specialists and advanced services concentrated in urban centers. So for like Anibal and people with CES, we're working in very remote areas in order to get the right medications, diagnostic tests, getting our patients where they need to be to get the care that requires a lot of out-of-pocket costs for patients, transportation, food, lodging. And CES has done their best to try to subsidize and reduce this, but it's a lot of costs for patients. And in particular for Gerardo, who had been trying to get to Mexico City, the family had spent a lot of money on that, really leaving the rest of the family in more dire straits, and really affected the decision because we actually wanted to get Anna and do some of her care outside of the community, but the family had decided that that was not the right decision for them. And there's also underfunding of the public health system. Mexico spends relatively little per capita on healthcare, leading to shortages in diagnostics, medications, staffing. And that can lead to, like in this case, there was probably Gerardo had a missed HIV diagnosis. It delays tuberculosis and HIV treatment just because of this very fragmented care. Like if it weren't for our insistence, like getting these medications for the patient wouldn't have happened. And at the policy level, these systems don't happen by accident. They are shaped by broader social and economic forces, including uneven development tied to colonialism and global capitalism. We want to think about what we can do as healthcare professionals. And in our chapter, we talk about the 4 domains where we can really act. So at the individual level, we can educate ourselves. We can educate ourselves on structural violence and about the historical and social forces that affect our patients and their lives. And our mindset begins to shift. Instead of thinking about why didn't this patient follow through, we start to ask the question of what barriers are the patients facing. And it's also good for us to reflect on our own biases that we bring in to the clinical setting. At the interpersonal level, we can acknowledge power dynamics, approach our patients with humility, and tailor our plans to real life constraints, whether that's cost, transportation, stigma that our patients are facing. At the institutional level, we can reduce barriers where possible. We can minimize costs. We can practice accompaniment. We can recruit, train, and employ community members and partner with community groups. And at the policy level, we can advocate. We can support stronger health systems and social programs that reduce inequities. In Mexico, this could be by like strengthening Seguro Popular or the Prospera programs. I think the bigger picture is that, like we were saying, Mexico has underfunded healthcare systems, high out-of-pocket costs for patients, unequal access to services, and a broader economic policies that create these structural barriers. and that limit social mobility. And they can really affect our patients and their opportunities to be healthy. And so bringing in this structural violence lens helps us take away the blame of individual responsibility and helps restore like our own context compassion and helps us provide better care for our patients.
Thank you guys so much for sharing that. So we're going to continue that conversation, picking up on that piece about coloniality. And Colleen is going to take us through our case study set in Haiti.
Hi, everyone. My name is Colleen Keogh, and currently now I'm an internal medicine and pediatrics faculty member at Baylor College of Medicine and work at the county hospital in Houston and then also the Children's Hospital. And I was very fortunate to be a part of the HEAL class 16 to 18, where I worked with many of my great colleagues who are on this call. I worked in Gallup, New Mexico for the Indian Health Service, as well as I worked with San Vicente in Haiti in the Central Plateau. And that's actually where this case comes from. And was really glad that we were able to look into this case more because it did affect me a lot. And it really helped me to work, with my other colleagues on this case to understand it better, and especially understanding it from the structural lens to see, what happened in this case. So, in thinking about, many of you on the call are already familiar a lot with Haiti's history. But I think this is really important when thinking about this case. And so, in the Haitian history, we all know that Haiti became the first Black republic to acquire independence by arms. And it was, in that moment, so much, triumph for Haiti. But unfortunately, for the next 122 years, Haiti was required to pay reparations to the French just to be involved in the global trade. And then the U.S. also refused to trade with Haiti as well. And so although Haiti was the most successful colony at that time, it was very difficult for it to be an independent republic because of all these constraints placed on it by reparations, and then also by by its inability to trade and actually produce a lot of the products. And so that, if you can imagine that most of your budget is actually being used to pay reparations, it makes it really difficult to pay for healthcare, develop infrastructure. And so, we see a lot of that still reflected today. And so this was a huge part, of one of the, one of their struggles going forward. And now Haiti is the, poorest country in the Western Hemisphere with limited health infrastructure. And so, the main kind of thinking about this from, globally, or this case is that, non-governmental, a lot of NGOs work within Haiti, and they offer a lot of technical interventions. And they may, of course, they save lives and they are very important, but sometimes they can obscure ongoing sources of global health and inequities in these inequities on a larger scale. And so that's what I came to understand a little more with this case is, it's really about, of course, NGOs provide a lot of important resources, but how sometimes, they can also, hide the fact that there's really just these larger structural inequities. Next slide. So this patient, we actually, I took care of when I was working in the Central Plateau. And so I was working along with another Haitian pediatrician who was amazing and was my mentor when I worked there. And this case came in overnight, and then in the morning, the residents had admitted the patient, and they admitted the patient for the patient was 1 month old, and they admitted them for IV penicillin for syphilis treatment. So they were going to be there for about 10 days. But it was pretty clear when we rounded on the patient in the morning that the baby had Down syndrome and was tachypnic. And so a lot of you on the call know about 50% of patients with Down syndrome have congenital heart conditions. And so we were able to, put everything together and diagnose the patient with the congenital AV malformation, which is a very serious heart condition that in a country with more resources, the patient would receive surgery to repair it, and along with a lot of other services. And so that would be the standard of care. And at that moment, we were able to connect the patient to a nonprofit that did actually provide care and transport abroad for heart conditions like this. that couldn't be treated in Haiti. Haiti didn't have the resources for that. It was a pretty high resource surgery, but the patient did need a passport at the time. And so we were feeling hopeful for the patient in that time, that this surgery would, we thought, most likely happen, and that the patient would do well, because patients with this condition, once it's surgically repaired, can have a pretty good trajectory for going forward. And so we were feeling positive. But unfortunately, there was this big barrier for the patient, which was getting a passport. And as a lot of you all know, that a lot of the services and things related to the government in Haiti are in French, and everyone in Haiti speaks Haitian Creole, and so getting services from the government or getting things done, if you don't speak French and your primary language is Haitian Creole, many people don't actually speak French fluently in Haiti or speaks French at all, and so there's definitely this major language barrier that is, from colonial times, related to, French kind of still sticking around and being, used for a lot of business related things. And then there was also a major transport issue. So the mom would have had to transport the patient all the way to Port-au-Prince, to the capital, to obtain the passport, but it was very expensive. And so the organization, of course, was providing all these services, but there was this linkage in care that our organization, also, we were another NGO working in conjunction with the public hospital. We also tried to provide support, but ultimately the patient wasn't able to obtain this passport, and still had this barrier for this variety of different reasons. And so he had progressively worsening heart failure. And they also lived in an even more rural area than we lived in, which made it difficult for them to even come to our hospital, which was, fairly remote as it was. And then the Haitian pediatrician that I was working with, unfortunately, she was fired due to budget cuts at that time, at the NGO that we were working at, that paid her salary. And so because of the repeated, hospitalizations, the patient kept coming back to the hospital and getting sicker and sicker and worsening heart failure, which is the natural course of this condition, unfortunately. And, without repair, it does cause worsening heart failure. And so, at 6 months old, he was admitted for the last time, and he passed away at the hospital, having never, received his heart surgery and the passport. And so that was really heartbreaking, not just for us, but for other physicians, everyone at the hospital that we knew the patient well. And so this was a really difficult case, and we were able to talk to the patient's mother a few times and understand her perspective a lot about it, and it really helped us to understand the case better. So I'm so grateful that George Reconstant was able to work with us on this case and help us interview the patient and talk to her more in depth about it, and understand her perspective. Next slide. And so in thinking about this case, this was really hard to understand this case. We had this patient, we had a possible solution for them, but we just couldn't make it, to get the patient the surgery that they needed. And so, I think with Seth and Raphael's help, really analyzing this case and thinking about it, why this happened, what are the structures that came into place. And so taking the idea of structural violence, which we talked about in the first case, and adding this idea of a post-colonial analysis. And so there's structural violence that is apparent in this case. And then how does, post-colonialism play into that? So of course, the forced debt after independence, contemporary transnational policies, which we could, do, many presentations on all the policies that have affected Haiti, from trade, et cetera. And these are examples of structural violence. But then when you add the post-colonial analysis, so thinking about naturalizing empire and taking a position that goes against and beyond colonialism. So Haiti's present-day poverty and weak institutions are framed as products of colonial and neo-colonial exploitation. And you're thinking about the political interference in the economic policies that sort of contribute to persistent dependence on other nations and underdevelopment. And I think it helps to think a lot about how it's not just colonialism back in originally in the 1800s, but it's continued. These continued systems that are not allowing Haiti to continue to develop. And so NGOs, which often, maybe could be the heroes in many stories, but in this case, functioning as an anti-politics machine, just meaning that, really, of course, this, all and a lot of NGOs are just focusing because they, for whatever reason, that's part of how it works, right? Focusing on these technical issues, which is part of their job, right? But then it does make it harder sometimes to see these larger political and economic issues which are at play, right? Funding cuts, which we're all extremely aware of now, as having devastating effects worldwide, from funding cuts coming out of nowhere. Next slide. And so I think in thinking about this and kind of bringing it together, how can NGOs or people working in global health think about these things going forward, and think about, how do we partner in improving, or at least, make sure we think about these issues when we're, working in different environments, and working in global health. And so I think definitely improving the stability of funding streams and the services provided as best as possible, and thinking about how that can happen. And then partnering with local administration and Ministry of Health, to develop needed programs and empower local leadership. And so making sure that those partnerships are there and not just, working in a void. And then healthcare workforce development, which is always so important. And, working yourself out of a job, right? That's what we always think about in global health, is how do we work ourselves out of this job? And so that, it can carry on and sustainably in the future. So I'm just really grateful to have worked on this case, and thank you for everyone who contributed to it. That's it.
Thank you so much, Colleen. And you'll see that Colleen is also an author on this chapter. So we're going to move into our third chapter, set in Navajo Nation. And these slides are a little different. They're pre-approved by the Navajo Nation Human Research Review Board. I'm happy to discuss that later if anyone has any questions. So it's just another cover slide. And we did work with both the NNHRB as well as the Eastern and Central Agency Councils, the Navajo Nation Heritage and Historic Preservation Department, Chinle Service Unit, and others to make sure we had the permissions to move this forward. The subject of the case is also a co-author in this case. Lola is not able to join us today, but we deeply appreciate her partnership in her choice that she requested to be named in the project and to be a co-author. So we just want to honor her contributions here. And this is a little bit about that process, and the emergency of Lola Sosi as one of our co-authors here. This is just the abstract, which you could read in the book as well. And I'm going to hand it over to Claire to tell you a little bit more about the chapter itself.
Thanks, Lillian. So in this chapter, we're building our exploration of two key social science concepts around the story of Lola Sosi, who, as Lillian told you, is one of the authors of the chapter. Lola was born and raised as a boy, but strongly identified with girls and the things girls did from a very young age. She came in for bullying and scorn from people at her school and also from many close family members. But her grandmother and one aunt were really supportive. Her grandmother taught her the Navajo language and told her the story of Changing Woman, an important person in Navajo origin stories. So Changing Woman was one of the Nantlehe, who are people who embody both male and female characteristics. And some elders would describe these as holy people, connected to both the heaven and earth. In one story, Changing Woman herself played a critical role preserving the Navajo people by acting as a mediator between men and women during a disagreement that threatened the community's survival. So being able to identify with this important person made Lola feel like there was a place for her, after all, in the Navajo world. As she became an adult, Lola also found a queer community when working at the Navajo AIDS Network, and there she met friends who introduced her to the idea of being trans and started identifying as trans herself. Lola is now a patient in the only transgender care clinic serving the Navajo Nation within the Indian Health Service. The ability to get a hormone treatment through a gender-affirming care program has been literally an answer to prayer for her and has helped her feel more like who she truly is. Other clinical encounters, though, were a much more and are a much more mixed bag. For instance, when clinic staff insist on calling her loudly in the waiting room by a name she no longer uses. Lola has become an important public advocate for trans rights and trans acceptance, and we were so glad she was willing to co-author this chapter. Could I have the next slide? So Lola's story illustrates two key concepts in this chapter. The first is cultural competence, the idea that culture matters for health and for clinical care, and that learning more about it could help providers do more work. This was, as I'm sure most of you, all of you have encountered, this was a really important idea, but it was transformed by quite a few educational programs and health practitioners into a form of stereotyping. So Lola's story shows us in detail that all members of a community don't think alike, don't understand culture in the same way, and core cultural concepts like those of gender can be matters of really profound difference. Her story also shows that, though, that culture is really important. Navajo history made a path for Lola to make a life that works for her and shaped possibilities for her inside and outside the clinic. So culture is complicated and always changing, both within and across groups. Then our second concept is that of biopower. So the relationship between power and knowledge that's enacted through medicine, biomedicine, including the ways in which medical power as an arm of governance supports some people to live while allowing others to die, as the last chapter illustrated, right? And how people actively respond to those systems, whether they're working within them or outside them. So we show how biomedicine has understood and treated gender and how that's really changed over the last many decades and how it articulates with state and federal laws. That is something that has continued to change very rapidly, even since we first drafted this chapter. So Lola's story shows how both of these concepts well as we follow along with her relationship both to the Natlehe and particularly changing women and to transgender identity and also her encounters with the Indian Health Service. Next slide, please. And these are our really straightforward takeaways. Culture is always changing. Never assume that either the cultures or biomedicine or other cultures we encounter are good or bad, and follow the lead of those who are navigating their own lives and figure out how to support them to find resources that fit their needs. Thank you.
Thank you so much, Claire. And again, thank you to Lola as well for this really important piece. And of course, thank you to the Navajo Nation Human Research Review Board and the other entities throughout Navajo Nation, individual and group, who have supported this project through this particular chapter throughout its development. So now I'm going to hand over to Anoop. This chapter is a special place in my heart because this is how I got connected to the project. And thank you, Anoop, for taking us over to Chhattisgarh in rural central India.
Thank you, Lily. It's so good to be here and seeing so many people. Uh, so I worked at JSS, Jan Swasthya Sahayog, in Chhattisgarh uh, from 2017 to 2019. And this is where uh, I understood about constipation as such an important symptom of a big societal problem. So this is a story from Chhattisgarh, but probably very common across most of India. Uh, Next slide. So in this chapter, we will go through structural competency, which is the capacity for health professionals to recognize and respond to health and illness as the downstream effects of broad social, political, and economic structures. I never thought that constipation could be related so much to these structures, but then when I started working on this chapter, I learned a lot about these factors. Next slide. So constipation was always simple. If a woman is suffering from, or if a man is suffering from hemorrhoids, anal fissures, rectal prolapse, they probably have chronic painful constipation. You tell them to have good hydration. You tell them to eat a fiber-rich diet, give them some medications. So this is the standard medical history. And before the fellowship, this is what I believed was always the case. Um, Next slide. But as we delve deeper, we learned that this was not so simple. Uh, in rural areas, most of central India, Chhattisgarh, Madhya Pradesh, Bihar, Uttar Pradesh, where there are not a lot of jobs, a lot of development has not happened. Uh, Husbands migrate to cities like Mumbai, Kolkata, or Delhi for jobs. And wife and the other family members, they do farm and household work. Um, doing latrine or going to the toilet in the four walls of the house was not a culturally appropriate thing. So most women go 1 to 2 kilometers away to relieve themselves in the field. Now, men feel comfortable to do this any time of the day, but for women, they have to go when it is still dark. So they go mostly during dusk, like before 5 a.m. or 4 a.m. they have to go. So if they don't go at that time, they find it hard to relieve themselves for the rest of the day. Um, and if they go alone, they are vulnerable to assault in latrines compared to outdoors. So that's why they go in groups to the field. And if they miss 1 or 2 days, they are unable to stool in safe and timely conditions. So that makes it a very chronic and painful process. And once the pain starts, there is an aversion to the process of defecation, and this is a vicious cycle that continues. Um, so the standard medical history and default that mine was that chronic constipation will lead to hemorrhoids or anal fissures and can be treated with diet and hydration. I found it was not so simple and uh, much more insidious. Uh, so if we do a structural analysis, uh, there is a lot of gender-based violence, and you can see this in news reports across the globe that in India, gender-based violence is very common. Uh, there is limited funding of social service and sanitation. So we did have the the Swachh Bharat, which means that every house got a toilet, but then there was no water supply. So these toilets became basically storage places in a lot of the houses. Uh, and a lot of this has to do with underdevelopment of tribal areas in Chhattisgarh, but most of central India, essentially, Madhya Pradesh, Chhattisgarh, Uttar Pradesh, Bihar. Uh, and this is also connected to systemic marginalization of indigenous communities. You can see uh, a lot of Chhattisgarh, Jharkhand, where the indigenous communities are some of the most underdeveloped districts within India. Next slide. So what do we do about it? So we used uh, the structural vulnerability assessment tool to to assess this, but not only did we assess this, we assessed a lot of problems and learned how various political and social structures affect various diseases that we see in the clinics. So that was a very important learning for me, and a lot of this is shared in the chapter, and how to work on various levels of intervention. So at an interpersonal level, the village health workers assess their own and one another's bowel health. Uh, at an interpersonal level, they conducted examinations in the community settings. They were taught about uh, hemorrhoids, fistula in anal fissures, etc. At a clinic level, patients were referred to advanced care where needed. Uh, at a community level, we tried to understand this problem in a much more important way and talk about these issues and using the toilets that were provided by the Swachh Bharat program. Um, and then at a policy level, making water available at a village level became an important policy that JSS now works with various NGOs in the area and with the government. Next slide.
That's the end. Thank you so much. Anup, was there a last closing thing you wanted to say?
No, thank you.
Wonderful. Thank you so much, Anup, for sharing that piece. And if you're interested in teaching that one in the classroom, we have materials for that in particular. So moving a little bit north and east from there, we're going to head up to Nepal, and Isha is going to share our last case study.
Hello, everyone. As Lillian mentioned, my name is Isha. I'm Isha Narola, and I'm the co-author for this chapter titled Purity and Danger, Menstruation and Suffering in Nepal. I also lived and worked several years in far western Nepal, based out of the district hospital in one of the most resource denied areas of Nepal that faced this issue in our communities. So our focus today is Chaupadi, a socially enforced practice of isolating menstruating women and girls. It's persistent in parts of Karnali and Sudur Paschim provinces, which Acham district, where I lived, is located in. And it's rooted in the long-standing belief that menstruation is impure or unclean. It's a form of gender-based violence that has led to ongoing mortality and morbidity in the region. In this practice, this means women and girls are often removed from their homes during periods of menstruation, barred from touching food, water, livestock, and they're often made to sleep in isolated huts or cattle sheds. These conditions are often unsafe, cold, unhygienic, and the practice can extend also in the postpartum period for reproductive aged women. And while menstruation itself is a normal biological process, the conditions created by seclusion practices can be extremely harmful. Women and girls face increased risks of infection, exposure to environmental elements, including extreme heat and cold temperatures, and in some cases, violence or animal attacks. So there are broader implications. There are also broader implications, shame, fear, disruption of daily life, and for school-aged girls missing school. So impacting their education and opportunities to build themselves in economic empowerment. And in my experience, I lived in this region of Nepal in the far western region for several years. And my experience working in these communities, I saw how deeply embedded this practice was. And we would see year after year actual death and injury coming from this practice. But also learned how local advocates, health workers, and policymakers have been working to challenge it and support safer alternatives. So if we can go to the next slide. So today I'll briefly walk through the context of Chapati. I wanted to share some case studies as we've laid it out in this book. And yeah, to ground this lived experience, there were several case studies that we drew on, particularly among my colleagues, health workers that I worked alongside with to deliver care in Acham. One of my colleagues, a brilliant woman named Sonu Kadka. She was a community health nurse who was from Acham. Her father was born and raised in Acham district. It was her ancestral district. And so when she came to join our team, she initially stayed at her uncle's house, her father's brother's house with her uncle and his wife. And they were still deeply practicing and entrenched in the practice of Chaupadi. So they expected her to sleep in an outdoor shed in very unhygienic conditions during cold winter nights. And with her knowing the documented harms and deaths that occur annually in Acham linked to this practice, she refused to. And there was one particular instance that she shared with us where they had instructed her, directed her, and expected her to sleep in that shed, and she snuck back into her room and she slept in the house in a safe and hygienic environment. And she said the next morning it was incredibly tense in the family. She felt extremely unwelcome, a lot of silent anger directed towards her. And that's when she made the decision to leave the home and rent her own room. And her decision, and this was part of our discussion and exploration in the chapter as well, her decision reflects a rare economic and professional autonomy that she would have that many other women in the district that we lived in didn't have, to be able to kind of leave the home and find a room where she could rent. Another colleague of ours, Urmila Basnet, she was auxiliary nurse midwife at our hospital, and she is also from Acham. And her husband, what we found is some women who have tried to push back against this practice have found partners and allies in their husbands to support them doing so. And often what that looked like was hiding that from family members. So she concealed her menstrual cycle to his family. In many areas of South Asia, Nepal included, once a woman gets married, she's living with her husband's family. So her and her husband would conceal it from his parents, from her in-laws, to avoid the enforcement of Chaupadi until they could live independently. But the tensions emerged when her mother-in-law was living with them. And, it was, again, it ended up leading them to have to not live with his mother-in-law, which again, for a son, part of the social structure too is that as parents age, the son and the son's wife care for the elderly. So it caused a lot of tensions and fractures that intersected within her household and also in her professional life. The other case that we explored in depth was a community health worker, Lalita, who lived in one of the village development groups that she oversaw, and she was criticized by community members when suspected of menstruating, and people who desperately needed care would refuse care from her because she was menstruated or they suspected her to be menstruating. Um, so it just shows how the stigma extends to public and professional spaces, both impacting the community health worker, but also impacting patients who desperately need care and are refusing to even care or prioritize their own health because of how strong these social structures and cultural elements exist and dominate how they operate in life. The last thing I wanted to touch on was a series of cases that we also explored in quote unquote modern spaces of Nepal, where we interviewed women who are in leadership positions, are considered some of the most economically empowered, educated spaces in urban areas like Kathmandu. And what the practice looks like there and menstrual isolation looks like there is described as partial compromises, such as avoiding kitchen, maybe not sleeping in an outdoor shed, but sleeping in a cold basement, not being allowed in spaces of worship. So while also actively engaging in their family conversations about change. So what stood out to me was how deeply entrenched the menstrual isolation remains, even with women who are economically empowered, highly educated, and primary providers to their families. So together, these cases show that Chaupadi is not a singular rural practice, but as negotiated, it's evolving as a set of social expectations around menstruation and shaped by context, power, and constraint. And then yeah, social suffering. So as this relates to for social suffering, it refers to how human suffering is shaped not only by individual experiences, but by broader social forces like poverty, violence, and illness. And it helps us see how power through institutions, cultural norms, and inequity shapes everyday life and constrains people's choices. Importantly, these conditions become embodied over time, directly impacting health and well-being. Next slide. So finally, as we close out discussing the chapter, within the chapter, we were looking at how to address Chaupadi and the efforts that need to work both across social and medical pathways and at multiple levels within society. So looking at our cases, health workers, both biomedical and community-based, as shown in the cases in this chapter, can play a critical role by leading through examples. And several of my colleagues that were interviewed have done that, particularly our colleagues in Nepal, but also in the ones in urban areas and how they're trying to push those norms. and receive additional training supporting individuals and family who are choosing to abandon the practice. But broader change also requires sustainable public engagement, including mass media campaigns that operate at both local and global levels to shift norms and reduce stigma. At the same time, it's important now to view Nepali women not as a monolith. So women's experiences, their choices, agencies, it varies widely. And the response must reflect that diversity as well. So lastly, I just want to touch on policy and legal approaches, that also being part of this kind of multidimensional effort to combat this practice, strengthening existing laws, improving enforcement of existing laws, and increasing women's representation in decision-making spaces at all levels. Ultimately, meaningful change will only come through such coordinated action across these health systems, communities, and policies, and should be grounded in respect for women's dignity, agency, and their lived experience.
Thank you so much. And I love that the final chapter refocuses, on health workers themselves, as someone mentioned in the chat. So last but not least, we have a wonderful conclusion chapter that Robin is going to take us through.
For the conclusion of this book, we actually decided to look kind of across HEAL fellows, including a lot of the chapter authors, as they put these frameworks into action and look at their reflections on their experiences. And next slide. We came up with 5 pillars of global health praxis, which are listed here, and I will go through individually. The first pillar is about learning from one another. And so while each context that HEAL Fellows worked in is unique, people who have been marginalized face common barriers, both within and outside the healthcare systems. Fellows reported that learning from their co-fellows was really valuable, and seeing these common struggles, how these common struggles are approached in other settings, helped give them new perspectives. And this also provided a unique opportunity for learning across contexts in the Global South. Next slide. Our second pillar is acknowledging the complexity of structures. And so creating change in flawed systems is challenging and takes time. During their time in HEAL, fellows gained a deeper understanding of complexity, as everyone in these chapters have talked about earlier in this presentation. But the complexity, the interaction between and layering of power structures. And for some fellows, it was the intensity of the work that they were doing that led to a deeper and different understanding of this complexity. And for others, the fellowship exposed them to these frameworks and vocabulary to process, analyze the structural causes of inequity that they had been witnessing throughout their lives. Next slide. Our third pillar was around building a community of shared values. And this was something I think we underestimated when HEAL started. But consistently, our fellows reflect that being around other colleagues who have similar values and are interested in working towards equity made processing and addressing barriers caused by historical and current power structures easier. Multiple fellows reported that the support of their co-fellows helped in building their self-confidence and empowering them to advocate for themselves. And creating community among fellows made collaboration possible and gave fellows the opportunity to think about how they can create change together. Our fourth pillar was around redefining expertise. Global health depends on a wide range of expertise and experience, and on the ability for people to recognize the value of another's knowledge, even when it comes from very different sources. HEAL's work to try to disrupt the typical colonial narrative of who has knowledge. And in discussing with chapter authors, many shared that the most valuable part of this experience was the time they spent hearing patient stories, learning about how many of the things affected the patient and their family that happened outside of a healthcare facility, and expressed that learning from other members of the healthcare team led to a much deeper understanding of the forces that shape their patient lives and experience. and led to humility. Oh, go ahead. And the fifth pillar is around a cascade of knowledge. Participating in healing, contributing to this book has given fellows the tools to bring what they've learned to their communities and to continue teaching others. Many fellows reported sharing what they've learned, teaching in new ways or teaching new topics and developing new curricula or trainings. The focus on the continual process of learning and teaching and learning by teaching draws on the history of popular education and is central to the HEAL model. And we hope that this book can be part of that cascade, a result of learning together that will hopefully inspire further exploration by many people. Next slide. And so I hope that this whole presentation has shown the ways that learning and coming together in community and with our communities can transform the practice of global health going forward.
Thank you so much, Robin. Before we thank you to everyone, it's just been so wonderful to hear directly from all of you guys as we've been working together over the years on this. So of course, we want to acknowledge before anyone who's able to stick around, we'll have a few minutes for Q&A. But of course, first and foremost, we want to acknowledge the people who shared their stories with us, those whose stories are in the book, but many, many more around the world who influenced both these particular stories, the way we tell them, the over 270 HEAL Initiative health workers, staff, mentors, interns, partner sites, of course, including Indian Health Service, Navajo Nation, and Partners in Health, but many more as well. As we mentioned before, the book would not exist without Vincent Adams, but also would not exist without the support at different times of Yogesh Jain, Robin Tittle, Melina Salvador, Nivedita Keshav, and so many other colleagues. We, of course, thank the Navajo Nation Human Research Review Board. There's the project number for reference. The Committees on Human Subjects Research at the University of California, our anonymous reviewers, the Routledge Press team, and then, of course, our colleagues, mentors, students, patients across the University of California, including a number of different campuses. So thanks to everyone. It has truly been a labor of love by an incredible number of people. And even the 28 authors on the book, which is already a large number, represents so many more experiences and efforts and insights that have gone into this. Really quickly, Kia will throw these links in the chat for us. But as I mentioned, this book is open access. We worked really hard on that. Academic publishing is ridiculous price point. So we just want to acknowledge that. But say this book is free in its digital form to anybody, anywhere in the world. And that was really important to us. So feel free to read it for free, buy a copy if you would like. Those links will go in the chat. There's the next HEAL webinar that will also go in the chat. And if you're interested in joining the HEAL mailing list, that will also go into the chat. So I thought if Shri, you're available, you had mentioned responding to sort of a first question we had, sorry, just pulling up my own chat, earlier in the discussion, with all the admirable focus on social determinants of health, cultural competence, structural competence in the last 15 years, where does that leave clinical competence, especially physical exam and diagnosis? So either Shri or if someone else would like to jump in and discuss this. And thanks, Claire, for starting off with a response to this in the chat as well.
Yeah, I think that question was answered pretty well by one of our authors. I don't know if folks wanted to add. It was answered just that there's no competition between the two, like having structural competence and clinical competence, I think it's important. Both are very important and they both feed into each other and support one another. So I think that they're not opposing competencies. And so, yeah, and then I would just, before we get to other questions, thank you, Lillian and Jade, just the amount of work, like we said, it's taken 28 authors and 10 years, and also a huge push at the end from you and Jade specifically. So thank you so much.
Also, just to on that last question, as a current medical student, I see how oftentimes they're pitted against each other, and I experienced that too as a medical student in my first and second year. But I also found that the structural racism and health equity curriculum that we had at UCLA, even if briefly, I think even though some of my classmates might have not felt it to be relevant in the beginning, once they hit clerkships, we got a lot of feedback saying that it both helped them contextualize, I think, a lot of the clinical issues that they experienced on the wards, but even also kind of displaced some of the burnout that people experience not being able to or not feeling empowered to work on certain issues with their patients. And I think it also, I heard feedback as well from medical students that they were able to contribute to their teams in more meaningful ways, I think because of that extra context around the structural and health.
Thank you guys for those answers. And yes, Claire Winland for your comment in the chat as well. Luke mentioned synergistic, I would say. I did want to shout out that we also have a few authors with us today who didn't present but are here. I see we have Jimena Massa, Mike Harvey. I'm sure there's others I'm missing, but if anyone, authors as well, wanted to jump in and say anything either about your experiences or questions, you guys are welcome as well as from our audience. And Sri or Kia, did you want to say a little bit more about that next event?
We can at the end if folks want to stay on.
Okay. Oh, it looks like Mike did raise his hand. So yeah, Mike, let's unmute.
Sorry, I'm in transit doing doing things, but I've really enjoyed listening in on all of this. And I just want to thank you, Lillian, for pushing all of this forward and making it happen. And I know this took years and years, and just appreciate your efforts. This is just such a beautiful collection, and I'm glad we can use it in the classrooms and have people learn from all of these stories that all of these authors were able to, all these people and stories people were able to engage with. So thank you.
Yeah, thank you, Mike. And I know Mike has some great pieces about some of the deficits we've had in our global health medicine public health curriculums, and I do hope that this is part of as Robin was talking about, that sort of cascade of knowledge production that helps to produce resources to sort of to fill in those gaps, just like Jade was talking about at UCLA, even with all the pushback on that, when these pieces do make it into the curriculum, what a difference that can make for students, whatever points in their careers they get to engage with it. Thank you, Mike. And yeah, that is the hope that this is part of that cascade, and it really has been such an honor to work on with everyone. Okay, I think given the time and what we see in the chat and everything, yeah, Shri, do you wanna wrap us up here?
Sure. I think just, you can see on your screen a couple of things that are coming up. One of the things that heal, like this book, I think one of the gifts of being in community with all these noble friends that are working towards health equity all over the world, we can have the space and hold the container for conversations. And we have these series of conversations that we've been having. We had one on Indigenous health and some phenomenal folks advocating for graduate medical education with Indigenous rights. We had a conversation on a lot of the Medi-Cal cuts that are happening and Medicaid cuts that are impacting and ICE raids that are impacting communities all over the country, including California. And then we're going to have one on June 2nd that is talking about kind of how we think about, in light of all the USAID cuts and global, the Lusaka agenda that some of you might have seen, of how we think about the future of global health and global health funding. And we have some phenomenal, one is Brown, who's here, who's a HEAL alum, Vincent, who works extensively on policy, a brilliant mind, and then Nidhi, who's at the Gates Foundation, but was formerly at USAID. So three pretty powerful panelists on June 2nd. Kia, anything to add?
I think you covered it, Shri. The registration link is in the chat, and we'll be also sending that over email with some of these other links, so you have that.
Yes. Wonderful. Thank you so much. And the other author I wanted to shout out, I realized as we were chatting earlier, Leah is also here. So yeah, just thank you so much, everybody, for making the time on a Sunday morning, afternoon, evening, depending where you are, for coming together for this. It really, yeah, has been a decade-long process, reflective of so many people's efforts. And we're just so excited that this is out in the world. Let us know how you're using it. Ask us for materials. Please just be in touch and be part of this continuing conversation. So thank you so much. Kia, we can wrap up the recording here.